I do think high levels of blood sugar have the potential to feed cancer and promote cancer growth. I do believe that. And people have done this kind of work for ivermectin, fenbendazole, and these other alternative therapies to say, do we see any association here? And we haven't seen any data that supports it. And then for the clinics that provide those things, they don't provide any data that suggests they work, which kind of tells you they likely don't. Whereas the GLP-1 stuff, none of the people that are publishing this data, to my knowledge, likely have any financial interest in it. It's just there seems to be something there. And maybe it's association, maybe it's causation. We don't know, but there does seem to be some signal. We know these are biologically active compounds. They do hit receptors that are present on multiple different cells in the body. And there's probably a mechanism to be found. We just haven't found it yet. Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everybody, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon, and today I am joined with Samantha Murrell and Rob Swanda, and we will be talking about GLP-1s and cancer, things like Ozempic and that class of drug. So kicking us off, Samantha and Rob, I'll let you both introduce yourself, and then we'll hop into the content.
Hey everyone, Samantha Murrell. I'm a patient advocate. I have stage IV lung cancer with a HER2 mutation, and I'm excited to talk about this topic.
Hey everyone, Rob Swanda here, science communicator, helping to take the complex and make it simple, and excited to also dive into this exciting topic.
Yeah, and I think both your input will be really helpful here, particularly taking super complicated stuff like these GLP-1s, which kind of seemingly everyone and their mother is on, and then and diving down how that might be somehow relevant in cancer and what data makes us think that may be true. And Samantha, I want to, kick it with you because you were the one that pitched this topic. You've been seeing a lot of the buzz around the water cooler about GLP-1s and cancer. What have you seen?
Yeah, there was a lot of attention that was given to GLP-1s and cancer during ASCO of this year, and it definitely caught my attention. I'd actually seen a bunch of articles prior to ASCO, but the ASCO research kind of validated what I had been seeing. I essentially have just been down a rabbit hole ever since about learning about GLP-1s, what the mechanisms are and how it works. Is it related to weight loss? Is it unrelated to weight loss and things like that? And I've polled a lot of people taking GLP-1s in the lung cancer space. My number one concern was how does it interact with the therapies that we're on and things like that. But it seems to be general consensus that a lot of oncologists are on board, at least with individuals that need to lose weight or should lose weight to have GLP-1s plus their therapy that they're on for their cancer at later stages, but also the stuff that came out of ASCO was really compelling for earlier stage cancers in terms of progression, free survival. So there's just a lot of buzz right now. And so I really wanted to dive into it. A lot of people have lots of questions about it. We've definitely tackled the ivermectin and the fenbendazole stuff. And so I'm like, okay, well, let's get on to the next hot topic of GLP-1s and discuss it and break it down and have a candid conversation about it.
No, I think that sounds great. And then, Rob, you had a chance to dive into the literature a little bit. What did you see around GLP-1s and cancer?
Yeah, there's some really interesting stuff going on, especially with some large-scale studies that have followed individuals who were taking medications of GLP-1s for both diabetes or for being overweight. And they had reduced occurrence of cancer, reduced risk factors associated with certain types of cancer. So it really was interesting to kind of see some of this evidence starting to come into the field so we can start diving into what's going on. But some of the information that I felt was lacking in the papers was just mechanistic based. And I think that that's some of the information that we are excited to kind of hear about these studies that are coming out from ASCO. We have future studies that are now enrolling is what is it that could actually be triggering this decrease in cancer occurrence when an individual is taking some of these medications. So it's definitely an interesting and exciting field, and it's headed in the direction that's showing some promise. But, as the scientist in my head, I'm always looking for that mechanism. I want to know like A's leading to B and B's leading to C. So I'm excited to kind of see like, well, where is this going to go?
Well, and I think the mechanism you mentioned is so important. And right now, before we dive in, I want to make clear to the audience that we're talking about associative data. This is saying that people who do X have a lower risk of Y. We haven't demonstrated, and the stuff we're going to be talking about hasn't demonstrated that X leads to Y. And the example I like to give here is that, a couple decades ago at this point, there was a study that came out that showed that drinking coffee was associated with lung cancer. And people saw that and made the conclusion that drinking coffee led to lung cancer, when in fact, further studies demonstrated that individuals who drink coffee are more likely to smoke. If you have one addictive habit, you're more likely to have an alternative addictive habit. And the other addictive habit is the one that led to the outcome, the lung cancer. But for a little while there, people made that association that, oh, maybe coffee's bad for me because we just see this thing that people who drink more coffee, there was even a dose response. People who drink more coffee are more likely to get cancer than a little bit of coffee. But, I don't know if you grew up around smokers. My family was full of individuals who smoked a lot, and they would chain smoke and chain drink coffee. So we have to be really careful about over-interpreting data when we see two things that are somehow linked. They may be linked. The coffee may be associated with increased risk of lung cancer, but it may not be a cause. That data may still be really useful. We just have to interpret it in the right way. Now, I think the GLP-1 stuff, I'm excited to get into because I do think it's stronger than at least the data, and my sense is it's more believable than the coffee kind of associative characterization that I just gave. So I actually think it's a promising area. So diving in, Samantha, I'm curious what the patient response has been to these studies that are coming out that we're going to go into a little bit with Rob. But at least from the buzz that you've heard, what has been the patient reaction?
Yeah, I think, the main hot topic is it because people are losing weight, or is there another mechanism? That is like ultimately the summary of what we're trying to figure out, right? And that's kind of the hot topic sentence of what people are trying to figure out. And so, as I mentioned, I polled a lot of people that are on them. They all are of higher weight and do have weight to lose. The question becomes the subset of population who are of normal weight. Is this a good idea to do, or is it not a good idea? There's a lot of discussion about, and rightfully so, someone of normal weight who goes on a GLP-1, losing muscle mass, not eating right, having severe weight loss is a terrible idea when you have cancer and are going through cancer treatment. And so muscle mass is extremely important. And correct me if I'm wrong, I believed it's tied to better outcomes if you have more muscle mass.
It is.
So it's definitely a back and forth of like, oh, is this a good idea? Oh, is this not a good idea? Even the people that are of higher weight who are on it are like, oh, I don't know if this is good. This could be good. This could be bad. But I will say a lot of people are seeing side benefits. And what I mean by side benefits is, obviously it varies depending on each person. Everyone's different. Some people feel like they have more energy. Some people feel like they are really tired. So there's like two different sides of it, right? Some people feel like the side effects of their treatments have been lessened because of it. So there's just some really interesting, like anecdotal things that I'm just hearing about the people are showing positives and some negatives. And the question is it because people are eating less? Is it because they may be eating healthier, making better choices? And so those are the consequences of that. Or is it not? So there's a lot of unknowns, and I'll openly say, because I talk about it, I'm taking a very small dose of a GLP-1, and I'm keeping my calories, I'm keeping my protein. Nothing has changed. I have not lost weight, but I have seen benefits. Again, that's just me personally as an individual. But I do have a lot more energy. I'm weirdly upbeat, and I can't explain why. I have less itching. My side effects of my targeted treatment is itching. I've dramatically been able to reduce my antihistamines because I'm itching less. So there's some weird stuff where I feel like I'm a little bit of a scientific experiment for myself because I am not changing my food intake and calories and things like that. But again, this is Samantha. This is my experience, and every single person is different. Someone else could do the same thing as me and have horrible side effects. It is totally independent of each other. But those are kind of the hot topics that are being talked about right now.
And before we dive into, our musings as to how it could work, if it does work and everything, and the data that we see, what was the bit of data or what did you see that made you feel compelled to try it?
For me personally, it was the inflammation, the mechanism around inflammation. And again, I'm not a doctor, so I'm probably going to butcher this explanation, but there was a lot of talk, or that I saw at least, around the theory of that it could target inflammation. Again, the question is that because people are losing weight, or does it just target the inflammation pathway independently? But there's been a lot of data come out recently about lung cancer and predisposition to lung cancer and related to inflammation and things like that. And so I kind of put two and two together and was like, well, if I can reduce my inflammation or slightly cut down on that pathway, could I inhibit some action in my cancer, slow it down? I don't know. I'm spitballing, right? And try and target that mechanism with the understanding that cancer will always find a way. There's 500 mechanisms it works off of, but is this one that sparks when cancer reawakens or wants to try and progress? I track my inflammation markers. My oncologist tracks them for me. Right now, they're really low, but when I was diagnosed, they were through the roof, off the charts, like insane numbers. And so I know that I get inflammation from my cancer. So how can I inhibit that action? It's a long shot, but for me, it was worth a shot, just to at least try and see what happens.
Yeah, and I think the point you're making, a lot of times the inflammatory markers are really elevated when people have unimpeded cancer growth or large volumes of cancer. So you're saying the data that this may impede more really chronic inflammation rather than short chronic inflammation, meaning it's there for a long time, which can really suppress actually the function of the immune system, which is different from short-term inflammation, which is sometimes anti-tumor. So I want to be, we tease apart, and we're being very generalistic here. These are really complicated pathways, but it was that chronic inflammatory immune suppressive element, or at least against the cancer, that got you interested.
Yep.
Was there a certain outcome you had seen in terms of the data, or was it more of that theoretical mechanism base?
Very much theoretical, grasping at straws, hoping for the best. But, to me, the data, again, the ASCO data, and I know we'll dive into it, there was one that specifically talked about lung cancer targeted therapy. And while it wasn't related to my mutation, it was other mutations, and how they saw people have longer progression-free survival taking targeted therapy in a GLP-1 instead of a targeted therapy on its own. Again, what is that mechanism? I don't know. But that to me was pretty compelling. And I was like, I'll give it a shot. The irony is, since I've started talking about this, and because I kind of say like fenbenazole and ivermectin didn't work for me, people are now saying online that I'm definitely being paid by big pharma because GLP-1s are, of course, from pharma. And so it's like,
are ivermectin and fenbenazole not from pharmaceutical companies?
Apparently not, according to conspiracy theorists. But yeah, apparently I'm being paid by big pharma to talk about GLP-1s and say that ivermectin and fenbenazole didn't work for me because I'm being paid, which is kind of funny.
Well, and to our knowledge, I don't think any manufacturer of a GLP-1 sponsors the podcast, but I should
No.
articulate that. At least if they do, I don't know about it. But yeah, so that's an ironic statement there.
Yeah.
And I want to dive into my opinions, of course. But Rob, I want to hear from you about, what does the data show? What do we know so far? What did you dig up?
Yeah, some of the things that were exciting for me to jump into after Samantha suggested this topic was first just seeing the expanded indications for GLP-1s. So when they first came out, they were for type 2 diabetes. They then further were expanded into individuals who were overweight. Now we see that they're even being used for individuals with cardiovascular risk disease and with obstructive sleep apnea. They're being studied for other things too. So I feel like we're seeing that there's more conditions that can benefit from this medication. So that was one interesting point where I see, okay, there are studies that are ongoing to look at further use of these. The second thing was, if we go back a couple of years, there was actually another medication that was used for diabetes called Metformin. And this medication further got expanded access after individuals saw that it was being used to help treat a condition called PCOS. And then now it's even being further used to look at certain types of cancer and could it be beneficial there. So then it got my brain thinking about all these different pathways that are going on in the diabetes field. And then now we're seeing some type of overlap, almost like a Venn diagram, right, with certain types of cancer. So that was like, there's something that's going on there, I think, that needs to be teased out, whether it's just supplemental to somebody getting another treatment, whether it's completely independent on its own and maybe it's not as beneficial as a targeted therapy. We don't know, but there could be something there that needs to, try to find what that mechanism might be. So that's what was interesting to me in the first place. So the first study that I saw was back in 2024, and they looked at individuals who had diabetes, type 2 diabetes, and they were receiving 3 different types of treatment for their type 2 diabetes. One was GLP-1, another was metformin, and another was just insulin. And what that study found, just again, population level data, as Kyle mentioned in the beginning, just kind of looking at broadly what's happening to these individuals and their risk for cancer as they're receiving these different medications. And the groups that actually saw decreased levels of cancer risk associated with 13 different types of cancers were those on GLP-1s and those on metformin. But there was no decrease in associated risk with cancer for the individuals who were just taking insulin.
Was the effect roughly the same between the GLP-1 and metformin?
Let me look.
Yeah, while you're looking that up, the reason I asked the question of, is metformin and the GLP-1 class similar in its ability to prevent the, this is really new occurrence of cancer, is if the rates are roughly the same, then you might conclude that the mechanism there is shared. So it may be something about glucose control. It may be something about weight management, both of which can lead to weight loss. And rather than, is it the hormonal effect of one versus the other, a direct anti-tumor effect. So it gives you some sense of the mechanism. And usually, if we're able to find out why one class of medicine isn't a super drug, figure out shared characteristics between other drugs, it's more likely to be true. So I think if we have a unifying mechanism between those and data around that mechanism is consistent in the groups, then it's more likely to be accurate.
And I do know a lot of cancer patients that take metformin, even though they don't have diabetes. They do take it because of that data that you're talking about. And people are curious of, okay, I'm taking metformin, shall I switch to a GLP-1? Is there more benefit? Are there more pathways from a GLP-1? I guess that's the question, but metformin is definitely one that people take off label.
Yeah, the side effects are not subtle, unfortunately. Yes. People get a lot of diarrhea. They don't feel very well on metformin.
Yep.
And from my perspective, a lot of times when people are evaluating these, I guess we'll call them alternative, it's alternative to a traditional chemotherapeutic or cancer-directed medicine. A big element comes in is, what's the risk? For things we've talked about, ivermectin, we've talked about fenbendazole, there's risk of drug-drug interactions, there's risk of the financial harms, there's, without any clear known biologic evidence, I feel differently really about things like metformin, about GLP-1s, because we know they're biologically active. They're designed for use in humans. We know the things they bind to. We have a lot more comfort there. And then GLP-1s have not been around for very long, but even still, a lot of data has come out evaluating them. And I think usually when there's a there, as we say, like when there's something active, this is the kind of signal we see, is that people will get together these large databases of patients, and they'll find, slivers of signal that will lead us down the right path. And people have done this kind of work for ivermectin from bendazole and these other alternative therapies to say, do we see any association here? And we haven't seen any data that supports it. And then for the clinics that provide those things, they don't provide any data that suggests they work, which kind of tells you they likely don't. Whereas the GLP-1 stuff, none of the people that are publishing this data, to my knowledge, likely have any financial interest in it. It's just there seems to be something there. And maybe it's association, maybe it's causation. We don't know, but there does seem to be some signal.
Can we talk a little bit about the glucose aspect of this? So
Sure.
you briefly touched on glucose with metformin and GLP-1. So, the old saying of sugar feeds cancer. And so a lot of people are like, see, sugar does feed cancer. If GLP-1 and metformin are controlling cancer in some degree, does that mean that you should arguably completely cut cancer out of your diet and then you will starve cancer? So I would love you to either debunk that or talk about that a little bit more, because that's kind of a thing that's being talked about too.
Yeah, I think cutting sugar out of the diet is a huge topic that I still have, almost weekly in clinic. And the reality for most individuals is your blood sugar is going to remain roughly the same unless you have an impairment in your sugar metabolism, unless you have some form of diabetes or prediabetes. And in those cases, when I do have patients who their glucose management is challenging because of insulin intolerance, or they don't make insulin, in those cases, I am really strict about their glucose control. I do think high levels of blood sugar have the potential to feed cancer and promote cancer growth. I do believe that. For most people, though, you don't experience that if you have really good insulin control.
Right.
You and I can eat a big slice of cake, a lot of complex carbohydrates, and a lot of simple carbohydrates, things that are absorbed quickly and things that are absorbed more slowly. And our blood sugar isn't going to spike all that much.
Yeah.
It's going to stay fairly stable. So I do agree that you want really good glucose control. The challenge is your body does a pretty good job on its own, unless there's an impediment. And in those cases,
I would agree with that, because I literally did that test where I ate a piece of cake and then I did my blood sugar because I was curious. And you're right. I mean, I stay around a certain range and just hang out there regardless. So it's pretty interesting. And I think it's a misconception that people are like, oh, I'm amped up on sugar right now, I'm all like crazy. When it's like, actually, if they did their blood sugar, it's probably not that high.
The opposite is true too. A lot of people say, oh, I have a sugar crash. And sometimes that will happen, but if it's to the point where you're passing out or something, that's usually not sugar. Yeah. We do these tests in the intensive care unit where we monitor blood sugar every hour, and we don't feed someone for 3 days. And, almost never is that test positive to where they actually don't produce enough sugar. Yeah. So yeah, I think, but hey, that's serum glucose. Maybe if there's a direct effect on the tumor from these molecules, we don't really have a lot of evidence of that to my knowledge. And if there's a scientist out there who does research in this field and wants to correct me, reach out. We'd love to hear it. But that could be a different factor, how the cancer is metabolizing things, that does matter. We just don't have evidence that these compounds are working in that way yet, but they may, they may.
So this study was using something called a hazard ratio, and it's just a way that researchers can compare how something happens in one group versus another over time. So it's perfect for things like cancer, or even if we're looking at survival. Now, if something has a hazard ratio of 1, it means that the two groups have the same risk. So that's what they found with metformin versus GLP-1. So it was like toggling in between 0.95 to a little over 1. So they didn't really see much difference between those two groups and the groups that are just taking insulin. So I don't have a clear answer between exactly how different the numbers are. Essentially, the graphs really like overlaid on top of each other if you look at the graphs. But then when you compare those to insulin, there's quite a large separation where those numbers drop below 1, meaning that the individuals who are just taking insulin compared to the GLP-1 or the metformin have now a higher risk of whatever type of cancer they were investigating for that particular graph.
Well, that data, to your point, Samantha, individuals who are on insulin for their glucose control versus a patient who's just on metformin, that's a different patient. Someone who has mild type 2 diabetes can be on metformin alone, but usually we escalate to insulin. So you may have other reasons why that patient isn't doing as well. So, and I think the data that we're going to get into with the GLP-1s, we have to keep these caveats in mind. Why may someone be on a GLP-1 and what are the effects of the GLP-1? And I love how you went into that proactively too. You had the same considerations I do. That's, are any positive effects we're seeing because of weight loss they may be having? I'm also wondering, hey, might it be slowing absorption? And that matters for the volume of distribution. Does the amount of fat tissue that one has dilute your drug out in some way? So the serum concentration isn't the same. Usually we can detect that a little bit in phase 1 studies, but nothing's perfect. So is that something we're missing? Is the type of person that proactively goes out and puts themselves on a GLP-1, are they doing better because they're willing to do other therapies? They're willing to do more things, and those other things are associated with improved outcomes. Do they have higher resources? They can afford it, if it's not from insurance. So there's all these caveats that we haven't controlled for. That doesn't mean the effect isn't real. We just have to take it with a grain of salt.
And I think one thing too that's interesting with the GLP-1 medications, like if we use semaglutide as an example, is that it's a modified form of our own hormone of GLP-1. So is there also something in those modifications that may also be contributing to this seen effect? I don't know. There's just throwing out hypotheses as we do, and maybe it's something to do with the fact that it does have this long fatty acid chain that helps it to stay in the body longer, so it's not metabolized as quickly. It has a couple amino acid modifications, so it's not degraded by enzymes as quickly, allowing an individual to take it, once a week or once every 2 weeks, whatever they're prescribed it at. So that way it is lasting in the body and you're not having to take this daily medication. Maybe that's also playing into effect. Like, I don't know, but it could be something worth investigating if somebody is looking at overall the biochemistry of the molecule itself.
Well, leaning into your expertise, Rob, we didn't even get into what these drugs are and what do they do.
Right.
Maybe we should start with that. Now that we're halfway through,
you jumped in.
yeah, we were just chomping at the bit. So, Rob, can you let us know what GLP-1s are, what they do, and how they work?
Yeah, so there's a couple different categories, I would say, of GLP-1s. You almost have like class 1, which you could think of like liraglutide or something. This was done really early on. These were really just for individuals who were type 2 diabetes. And this was a daily injection. It actually started out as somebody would have to take this medication every day, typically sometime after they had a meal. And it would help them to regulate their insulin because GLP-1s have effects on insulin levels, on satiety, and helping one feel feeling full longer. But then it kind of evolved into, okay, how can we make this medication last longer? So the GLP-1 hormone is what they're trying to mimic here by making the molecule known as semaglutide. And it's a modified form of that hormone with some amino acid changes. So it's not exactly identical. So it's not going to be broken down. It's not going to be attacked by enzymes in the body, because typically when our bodies produce GLP-1, it's broken down pretty quickly within, I would say, minutes to hours, right? It's not a constant thing that's going to be circulating. However, with these GLP-1 medications like semaglutide, manufacturers wanted them to last longer in the body because, again, it can prolong those effects that we're seeing that are beneficial for individuals who have type 2 diabetes, which they were studying them for. So they added on not only those changes to the amino acid changes, but then they also added on a long fatty chain acid. And that just helps to essentially protect it while it's in the bloodstream from being degraded, as well as attaching to parts of our blood cells in order to allow it to exert its effects. So these modifications really just help to enhance the effects of this synthetic form of the hormone that naturally our bodies would get rid of quite quickly, but now we have a longer period of time that it can last in the body. And then that's essentially class 1. I kind of put those two in one class. Others may disagree. And then now we're kind of moving into type 2, which you may see commercials on, known as trizepatide. It's again, essentially a synthetic form of GLP-1, but now we're also attaching it to other receptors. So you may see GLP-1 receptors as well as GIP receptors. So these are just other forms of receptors in the body. These are agonists against those receptors. So think of it like a lock and a key. And they're also involved in similar pathways. They're involved in insulin regulation, helping one feel full longer, helping one to maintain their satiety after they've had a meal. And then I would say future forms of these GLP-1s are adding in other components with GLP-1s. So there's something on the market, there's something in clinical trials called cagrisema. That's going to be GLP-1s plus amylin, which is another molecule that is made by the body that allows us to kind of follow the similar pathway for diabetes or for obesity regulation. And then we have even other forms such as retatrutide that is also being looked at regarding GLP-1s, GIP, and then also glucagon receptors. So they're constantly evolving. They're looking for more ways that these can last longer, that they can target more receptors. And then there's also companies who are looking into, can we move this from not just a weekly injection, but say to a monthly injection? We've seen that with other medications in the past, such as those for HIV, for example. We've gone from daily to monthly to now every 6 months, and people are investigating, is that even something that's possible for things like GLP-1s?
Yeah, I don't think they're even pushing to oral now. Yeah, pills.
Sure.
So yeah, and that I'm happy we laid some of the foundation now that we're halfway through. And I've got the abstract up here, Samantha, from ASCO, and this is the one that was administered for lung cancer. And I'll read it. This is from Thomas Jefferson University in Pennsylvania, and the title for anyone who wants to Google it is "The Effect of Glucagon-like Peptide 1 Receptor Agonists on Outcomes in Metastatic Non-Small Cell Lung Cancer Patients Treated with Tyrosine Kinase Inhibitors, Real-World Retrospective Analysis." And what they did is they took 25,000 patients, and of them, about 2% were on these medicines, the GLP-1s. And then they essentially took a group of those 550 another matched, roughly similar size set, and they kind of compared how they did. And they found that for individuals who were on the TKIs, they looked at how many people are alive at 5 years. So this isn't necessarily how quickly did they progress. This isn't where did it spread to, things like that. This is big population data, and they used what they have, which was, are they still alive at 5 years? And what they did is they looked at a few different subtypes of lung cancer. And for those of you who are not in the lung cancer field, a lot of times we'll separate lung cancers out by the type of mutation that drives them. So they looked at individuals with ALK mutations, mutations in the EGFR gene, and mutations in the BRAF gene. And pretty much what they found is that for all of them, individuals who were on the GLP-1 medicines did better than those who were not. Now, some of the effects were pretty dramatic, but most of the time, the likelihood that someone was alive at 5 years versus not in the other group was about double. So the likelihood of being alive at 5 years doubled functionally if they were on the GLP-1s, which is a pretty stark statistic. We don't get a lot of statistics that strong in our data sets. So, and they did it across a couple of different types of lung cancer. And that's important because some of the medicines I see that they looked at together they cause weight gain on their own. One could have said that, hey, maybe you're just mitigating the effects of that. It made the medication more tolerable, so you could take the medication for longer. I would argue that, well, maybe it would be true in one subtype, but they've looked at many subtypes that have dramatically different treatments. And for all of them, the individuals who were on the GLP-1s, generally speaking, had twice as likely chance of living to 5 years than those who were not on them. So I think maybe just starting with that sentiment, the individuals who are not on them had half the likelihood chance of making it to 5 years than those who were on them. Rob, I'll start with you. What's your sentiment around that kind of statistic?
For me, that's a huge number, just to be able to get people to live, half of them to be that much longer. So it definitely, I can see why it sparks so much interest, and definitely would require like a lot more diving into to say like, why is this happening? And then on the contrary, it also makes me begin to think like, is there something that's related to certain individuals maybe developing diabetes, certain individuals maybe gaining more weight when they are associated with certain forms of cancer, and in this case, certain forms of lung cancer, than others? I know that's probably like a crazy thing to think about, of like, okay, could these cancers also lead to other, health impairments? But I don't know, it kind of starts to make this a very complex system of, okay, well, what is causing what and what is helping what when you have multiple different things going on with someone's health? If they are, if they're not managing their blood sugar properly, if they are overweight, if they do have a certain form of cancer. So to me, it just sparks more questions almost, and like more things that I want to begin teasing out that need more like singular variables in order to better understand.
Yeah, and I think it's part of the challenge with big retrospective, meaning we looked at people in the past. Data is, this was a group of 25,000 people, 500 of them got the medicine. So there's inherently, that's a bottleneck. Something is unique about these 500 individuals. We don't know what. And then they take the other 24,500 and try to find 500 that are matched using complex statistics. And, there's a saying I like that is all statistics are flawed, but some are useful. So you don't know the statistical method and the inherent biases in that statistical method that produced those 500 comparators to the people that got the GLP-1s. So maybe there's something wrong about that. Maybe they tried to match them and one variable wasn't perfect. And then you create a huge skew in the data. So now everyone in your comparator group does poorly compared to the group you were looking at. And I only mention these to say this is why we don't look at these data and call it truth, is because there's a lot of caveats to data that was done in the past. And that's why we always say the gold standard is a randomized trial prospectively. So the ideal way to look at this in the future would be to say, we take, a large group of people, we'll say 1,000 or so, half of them get put on these GLP-1s, half don't. And then you monitor how they do. And you say, did that effect that we saw in this data set play out in real life? And they're randomized, so they don't know what they get. You don't know what they get, and you only find out later. That being said, retrospective data is often, meaning data that was collected from stuff that already happened, is often all we have at a given time. And you make the best decision you can with the data that you have. And I kind of share your assessment, Rob, that looking at data that's this stark, we don't often see data this strong retrospectively with these hazard ratios of 0.5, and one went down to less than 0.2, meaning there was a roughly fivefold benefit of being on them. So that tells me, well, maybe there's a confounder in there that's really important, something that is skewing the data and you don't know what it is. So maybe it's totally not real and there's just an artifact in the data. But then I get to the point, well, if there's a chance this is that strong of a benefit, well, what's the risk of trying? And Samantha, I think this is where you landed. So I want to pin that to you. In your calculus of risk benefit, seeing how strong this effect was, how did you land on trying?
Yeah, as I said before, like my main concern was, I maybe have 5 pounds to lose if that. I did not want to lose weight. I didn't want to lose muscle. So I went back and forth for quite some time about it, but my husband was educating me how that if I ate the same amount, if I had the same amount of protein, I would not lose muscle. So I proceeded to go ahead. Like I said, my husband's on one, so I kind of anecdotally got to talk to him a lot about the side effects, what he went through in the initial stages, things like that. And to me, the pros outweighed the cons. I'm like, why not? I normally handle medicine pretty well. What's the harm? Like I said before, my main concern was the interaction with the targeted therapy, like what might happen there. But I have a theory now. You might laugh at this theory. You're like, oh,
already
gosh,
laughing.
another theory.
No.
I'm wondering, given that the stomach slows down so much, that is it possible that you're actually absorbing more of the targeted therapy than you were before because it's being processed slower?
Maybe. I'll say the way we do the dosing is usually in the early phase studies, we administer it how you're going to administer it, and then you draw blood and you measure it. And that's how we figure out what the dose is.
Mm-hmm.
So I guess if your theory were true, then you would be getting higher doses of the drug. And those higher doses would have to be associated with better tumor control.
Right.
Which are all assumptions. They may end up being true, but those are the assumptions that must be met for that to be true.
Yep.
And a lot of times the early phase trials, they find the dose that higher isn't going to give any more benefit, but it might give more toxicity. It might give more symptoms. But, that's in one context. We don't know what it looks like. Maybe it changes the speed of absorption. Maybe,
right.
We don't know. I think it's a reasonable hypothesis,
Yeah. Yeah. And, what I will say is on my first and second week, my appetite was so severely suppressed that I was very worried. I'm not going to lie. I for example, it would take me 3 hours to eat my lunch because I was just feeling so full, like immediately. And I will say for someone of normal weight trying to do this in the initial few weeks as your body adapts, like you have to be very, very, very strong-willed to get through it. Because it was tough. It was very tough. Now I seem to have adapted a little bit. People that are of heavier weight go on GLP-1s, they usually go up a dose, right? Your body gets used to it, you go up a little bit, and then you come to find a level that your body can handle and that keeps food noise at bay and things like that. So my case is a very different scenario, but my body's adapted a little bit now where I am actually getting hungry again, feeling less full at the same dose, which has helped me. But oh my gosh, was it hard initially? And that's a balance, right? That's a juggling act of like, is it worth it? Is it not worth it? Because if I lost some weight, I essentially told my husband, I'm getting off it immediately. I'm not going to do it.
Well, and you raised a really good point, which is the people in these studies that we're talking about were on it for a clinically approved indication, most likely.
Absolutely. My use case here, big disclaimer, capital D, is I am doing it in a microdose, unapproved, in the sense of it's not standard of care, it's not part of clinical research, things like that. So,
and explain what you mean by microdose.
So I'm not going to go into the exact dose because I don't want to sway people and get people doing things they might not or should not be doing. But I'm essentially at around a quarter, a little bit more than a quarter of the normal starting dose.
Okay.
But, and you say, oh my goodness, that's so low. What the hell is the benefit? I have got exactly the same benefits as my husband, exactly the same side effects as my husband on the dose that he started on versus the dose that I'm on. So
yeah, when you said microdose, I thought you were going to say much lower than that. I thought you were going to say 100th of the. No. And my argument to you would have been, well, do it or don't.
Right.
I think titrating to symptoms with these kinds of things, and I'm not endorsing doing this. I don't think we have enough data to support an endorsement. But I think, if you're having the side effects of the medicine, you're likely at a physiologically relevant dose.
Yes, that was my theory.
Yeah, you're like, I'm not going higher. But no, I think this is one thing that I do struggle with sometimes when people are trying medicines out to see if they help as they start too low, and you don't know. The people in the study weren't doing subtherapeutic dosing. This is a big challenge I have with some of our alternative medicine colleagues who will do really low doses of something, and it's like it was never studied in that. But we do titrate to symptoms.
I do want to touch on. Sorry, Kyle, I didn't mean to interrupt you. I do want to touch on one of the benefits I'm seeing, because I think it's happening to other people. There are a lot of, in fact, I know there are doctors now prescribing microdosing GLP-1s for people with autoimmune diseases, rheumatoid arthritis, mass histamine, MCAS, I think it's called, the mass histamine activation in your body, things like that. And it seems to be providing quite a lot of benefit to those people too, which I find fascinating. And again, like I said, I'm less itchy. I have tons. I call myself a walking histamine, and essentially like that has been eradicated. And so I'm curious on that mechanism. Like, what on earth is that pathway?
What a great question for Rob. PhD Rob.
we can dive into a whole bunch of different things. I mean, inflammation is so complicated, right? There's so many different cytokines that are released by certain triggers, and then those bind to certain types of immune cells. They recruit more and they release different cytokines. So I mean, I don't have like a good hypothesis or a good idea, but if it is helping to somehow reduce the amount of immune recruitment, or it's helping to reduce certain cytokines that are being released, I mean, that's definitely would lead to a decrease in inflammation. A lot of the conditions that you talked about that have an approved biologic for them are specific monoclonal antibodies that will attach directly to that cytokine that is causing this cascade leading to inflammation and like blocking the pathway right there. So the person essentially is still suffering from that condition, right? But they're blocking that pathway because that signal to trigger the inflammation isn't getting where it needs to go.
Interesting.
I don't know if by having some type of GLP-1, we're maybe blocking the signal, or are we preventing that signal from even happening in the first place? And maybe that is due to something that we're consuming or something that we're being exposed to. I think those are definitely really interesting questions that could be explored more. But for it to be broadly applied to many different types of autoimmune conditions, it makes me think that there could be some type of blockade just directly off the bat as a complete hypothesis, just because all these different types of immune conditions, right, are having a different trigger. So it would be interesting if it was blocking all these triggers. So maybe it's actually just preventing, it's like almost putting a wall up. But I don't know, that's 100% a guess. And I actually never heard of that, Samantha. So I want to go read about that now.
There's a whole subreddit on microdosing GLP-1s and autoimmune diseases, and people are seeing miraculous things. But I will also do a disclaimer. There are some people that are getting the polar opposite response, almost like their body goes into hyperactive drive on top of what they already had. So you're kind of seeing these polar opposite responses. The majority are beneficial, but some people are like, this was the worst journey I've ever been on. It's made something I've had like 20 times worse. I'm coming off it. So it's kind of been interesting to see these two lanes of people having same things, but different reactions. I mean, it goes back to like my state of like, being super happy. There are a lot of people on GLP-1s that are actually really down because their dopamine is, and correct me if I'm wrong here, please, both of you, the dopamine is kind of suppressed a little bit apparently, and it's related to like the food noise and things like that. And so some people notice that their personalities are also a little bit dulled or dimmed. Whereas I'm like a hyperactive bunny, and I don't really understand why.
No, and I think it's important to hear the anecdotal experience from individuals, and I think there is a wealth of depth of experience that we get from that, because you don't get depth from studies. You get the things that are measured. No one's going to say I feel less itchy. You're not going to hear that in a study. But that's really useful to know, and sometimes those are the trails that we lead that we follow rather, and that leads us to a new discovery. I'm really optimistic actually about this having a potential effect in cancer. Maybe it's directly an anti-tumor effect. Maybe it's indirect in that there's weight loss, in that there's some other behavioral change that's associated with the med. Maybe the act of going through this and having to administer it to yourself every day or every week or whatever the dosing regimen is associated with increased medication compliance. We don't know what the actual association is, but I think the data we have is so strong here that it's worth evaluating. And unlike some of the other meds we've talked about, most people who are on these medicines, at least in the US population, benefit. Our population as a whole tends to be overweight. They tend to have negative sequelas of negative like side effects of being overweight. And these, I think, are, if this is the other thing that pushes someone to a healthier lifestyle, there's probably not a lot of harm in it. Leading, or I guess continuing on that, I want to relay for the audience another abstract that you sent, Samantha. So this was another one, which let me pick it up right here. So this is GLP-1 receptor agonist utilization and survival outcomes in a large U.S. community oncology cohort. This was also an abstract from ASCO, our large national cancer research, what's the word I'm looking for? Conference. And they looked at individuals who, 1,121 people who were on these GLP-1s. This was almost 500,000 people who are not on GLP-1s in this large data set. And long story short, they looked at a few different types of cancer. One was breast, one was prostate. And they found similar findings that individuals who were on these had about half the likelihood of a negative outcome, meaning usually progression or death. This one was overall survival at 2 years. And so it was pretty consistent. It was about half likelihood of dying over 2 years. And still, the numbers who are on, the number of individuals that they were looking at isn't terribly high because not as many people are on these GLP-1s. But you better believe that more people are going to be looking at these associations and trying to figure out what's going on there. And I think the question always becomes, well, do we have enough data for a recommendation? And right now with associative data, we probably don't have enough data for a formal oncology recommendation that this is going to likely help your cancer outcomes. Particularly, like you mentioned, Samantha, a lot of individuals are, if they're later in their lines of treatment, or if they have lost weight, if they have cachexia, it's not safe to be on these.
No, absolutely.
And that's another confounder here. Mm-hmm. You have to be well enough to be on a GLP-1 to be in that arm. So I think we're probably not going to see a recommendation from the clinical oncology groups anytime soon. What we'd want to see is some data moving forward where we do what I said before, we randomize individuals. Some people get it, some people don't. And then we compare how they do. Now, that being said, maybe we don't have a formal recommendation because the data is really weak. To the individual who's hearing this, who's making the decision for themselves, might it be a good idea to do it or not? Just like you're doing, Samantha. I don't have a personal objection to that. I want to make sure that people are doing it safely under medical monitoring. Keep in mind the negative consequences that can happen with these. So I would recommend strength training. You want to do things that are going to maintain bone stabilization and bone mineralization. So you're going to want to do weight-based strength training. And that would also ideally prevent the muscle loss. But if this is part of an otherwise healthy lifestyle change, that is a, pro-cancer support, like get yourself physically optimized, then I'm all for it. And like you said, the body is a machine. The calories you put in are energy. If you're consuming more calories than you expend, you're not going to lose weight. It's physically impossible. The tissues may redistribute. You may still lose some muscle mass. Yeah. So you may gain weight in another form and lose it in one form. But I think if you're doing strength-based weight training and you're monitoring your calories closely through an app, I personally have used MyFitnessPal. That's just easy, and I think it's free. It was when I used it. So those are the kinds of things that I would hedge against. And if you're going to try it, I would do those things. But I don't think it'd be necessarily wrong to try it, although I wouldn't endorse it, and I would specifically recommend it with the level of data that we have.
And one thing too, when you were mentioning lifestyle changes too, Kyle, is maybe there's also a benefit to this GLP-1 and these individuals who are already overweight. They're struggling to even want to get the motivation or be able to do some of these physical activities or have the energy to go do some of these physical activities. So then those lifestyle changes that they're now able to do also benefit them in terms of with their cancer diagnosis. And Samantha, even you, just knowing you, like I know you're already physically active, but now you're saying you have more energy. So like, is that going to help you just like step that up a little bit longer? So it could be, I don't want to say placebo because it's not clearly not like a placebo effect that someone's thinking about it, but it's almost not directly due to the medication, but it's due to changes that the medication allows somebody to be more present, active, make different decisions that also have been shown in literature to have benefits in, you know, their cancer journey. So just something else to think about. And especially I liked what you said, the adherence to medication too, Kyle, because like if someone's feeling better, maybe they are more likely to like continue to remember to take their medication, or they don't want to skip a dose because they're like, oh, this is going to give me side effects. Now maybe they're not experiencing as many side effects. There's a lot to unpack there. I feel like it could just be so much, and it could actually be some really interesting studies that hopefully will come out over the next couple of years of people doing exactly what you had mentioned and even taking it further.
Yeah, I mean, we don't know is the effect of, essentially of weight loss on how people do. Does someone who lost 200 pounds do better than someone who didn't? And that's what the match statistics is really showing you. Now, so therefore you would say, well, maybe it wouldn't work for someone like Samantha who doesn't have 200 pounds to lose. You know, we don't know. And that's why we have these caveats to say, I'm not going to recommend it. I don't think it's necessarily to the point where it's going to be a formal recommendation for all of our patients because we just don't know this stuff yet. But for the right person who, you know, who can take it safely and tolerate it, do I think it's going to be harmful? Probably not if it's under physician guidance, you know, but I'm excited to see how this plays out. You know, unlike some of the other stuff we've talked about, I do think there's biologic plausibility. We know these are biologically active compounds. They do hit receptors that are present on multiple different cells in the body. And there's probably a mechanism to be found. We just haven't found it yet. All right. Well, I think that's probably as good a place to wrap up as any. This one went quick. I really love to get into the heat of this with you both. Samantha, thanks for taking the time here and speaking about your personal experience with deciding to take this.
Yeah, absolutely. I'm always the guinea pig. It's I like being the guinea pig.
You're your own guinea pig, though.
I'm my own guinea pig. Yep.
And bringing us information that people are interested to learn about from the community, like that. You know, we may hear about it, like say at like ASCO, but we don't know what the community is talking about regarding what they're thinking.
Well, and like Samantha, how many times have we talked about a association thing, and you're like, this is associated with this, and I'm like, whatever. Yeah. And then I saw this, and I was like, oh, actually, there may be something there.
Yeah.
Yeah. So it's there are some rules that things need to follow to be promising, and I think this follows many of those rules. So we'll see as more data comes out, and I suspect we'll probably have an update on this in the coming years to educate everyone when that data does come out. But until then, thank you all for listening. This has been Cracking Cancer, and you can go to crackingcancer.org for more information. All right, well, I'll see you next time.
Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.